Hello, everyone, and welcome to another Unfiltered Productions. And this one, Cindy's all fired up about, and that's a good thing because we all love Cindy fired up. I'm Sherry Teague, and this is Cindy Kraft. We're the owners of K&K, and we use this podcast opportunity to get things off of our chest that we think maybe we have something in common with agencies about. But this one is something we've been passionate about since the beginning of the company. We were the first ones to go out into the country and do education on this. As an agency owner, we implemented this benefit before they had codes to process it. We found it in the Chapter 7 guideline for home health. It's always been there. This is not anything new. It's had a national ongoing, repeated legal situation that has repeatedly told everyone that it's out there. And Cindy, I'm going to let you introduce what this is, if anybody hasn't guessed yet.
It's maintenance therapy. I think, it's one of those, you're right. We came out of the gate with that was a very cornerstone issue for K&K. And it has remained that one the entire time. We did day-long workshops. We've done webinars. We've done pre-recorded content. And this was before the pandemic, before webinars were the most popular way to go. We committed to doing webinar-based maintenance education, trying to get it in the hands of as many people as possible. We knew then that especially that frontline clinician, getting them in for training is very difficult. It consumes a lot of time and dime. How could we make it as accessible as possible? To the point we've now converted it, knowing that attention spans have shifted a little bit of late, into a series of smaller pieces to try to capture key parts of maintenance therapy. But what's been on my mind, Sherry,
Hang on,
is
before you start, you
yes,
failed to mention that you wrote 3 books. One
what?
was a first edition for maintenance and home health and proper documentation of maintenance and home health. There was
Yes,
a second edition to that first one. And the third book said it was a maintenance education for all post-acute settings or home-based
correct.
settings. It included outpatient, it included skilled nursing, it included all these things. And that is still available for purchase. All 3 of them are available for purchase probably. And I'll add that link to this podcast for those of you that didn't know that. But that is something that's how passionate we were. Cindy Kraft and Dee Cornetti got together and they wrote 3 books on maintenance. And so go ahead, Cindy. I'm sorry.
Well, and this is not just a product placement issue. The first part of our latest iteration of the education, that webinar that covers the fundamental regulations is $7.
$7.
That's how desperate we are. Just please, somebody look at these, not because it's a get rich quick scheme. It's a passion area that says, how are we over a decade later from the Jimmo versus Sebelius case, still encountering, you know, I think I might do some maintenance. Or I've talked to my therapists and they don't like that idea. Or we do maintenance. You know that because we have like 5 patients we've had on for 5 years. It's like, oh, okay, hold on. That ends up in some recent articles we've seen when folks talk about, common denial reasons, this now idea that they're getting denied for long-term maintenance. Well, long-term is not tied to maintenance. Maintenance doesn't have a short-term versus a long-term trajectory, but I can see why if a patient has been receiving therapy for a year, 2 years, 5 years, you better be very prepared to defend that this is skilled, reasonable, and necessary. And in my personal experience over the last decade, doing audits of maintenance documentation, trying to help agencies ensure that what they're documenting is going to be defensible. When you start getting into this long time situation, I think familiarity negatively affects the documentation. I am very comfortable that what I'm doing is skilled. I've been with them a while. I know exactly how this is stabilizing their function, but my documentation starts to slip. And you start seeing a lot of re-educated, re-emphasized. And that right there, without context, can definitely set you up for a denial. But I think these denials then foster well, see, that's why I'm not going to do it. It's become this vicious cycle
But
of
Cindy,
I'm not going to try because I don't want to get in trouble.
we also think some of those denials are possibly because it is maintenance, it is not restorative care, and they're not billing it correctly with the proper codes.
Correct. We still remain the only post-acute setting that has a specific claim code for maintenance therapy. They don't have this in outpatient, they don't have it in skilled nursing facility or an inpatient rehab. Only we do. And some of that denial has been even in well-documented maintenance notes, but the claim said restorative.
Mm-hmm.
So their denial is you billed me for restorative care and you were not restoring function. Now, you can appeal and argue it's a billing code. It's not paid differently. It doesn't change anything. It's still just recording a therapy visit. But we know the time and dime of trying to deal with an appeal is just incredibly frustrating. But they've been in the right to say, I know what you said in the note, but you billed me for an improvement path
Right.
that just didn't happen.
Right.
But I think some of that around it, Sherry, what drove me to reach out to you about doing a podcast is this whole I'm still undecided or I don't do it. I think we need to stop. This has been, as Sherry just said, part of the benefit well before we got into the Jimmo situation. The reason we got in the Jimmo situation, and we've had the opportunity, thanks to our passion about maintenance, to personally know Judith Stein, the lead attorney who was successful in moving this forward with CMS. But it's been in there so long that when all that went down with Jimmo and people started talking about this new thing of maintenance, it was not new. As a matter of fact, CMS was forced to acknowledge that they were in the wrong, that their tendency to deny therapy in multiple post-acute settings, in particular, over a lack of improvement was never supported in the coverage criteria, was never covered by regulation. They had no legal leg to stand on to say lack of improvement in and of itself is why we're not going to pay you. But I think part of why we're here as therapists, I would love to see us further along this path, but our respective disciplines have been trained from day one that your job is to get people better. I mean, our own professional association, God love them, move to improve as your statement. I get it, but you've put it again in this, we've got to get people better. And the backside of that is if I evaluate someone and I don't think I can get them better, or I've been seeing them for a period of time and they've hit the plateau, which is somehow a bad word, then I'm supposed to discharge them. I cannot continue to provide their care. So when the Jimmo thing went down and people went, oh, okay, I don't think we fully acknowledged that therapy took that very differently because no one goes to the nurse and says, you know what? If you can't get rid of their diabetes, you need to stop caring for them.
Mm-hmm.
If you can't get rid of that heart failure, then you're done. Nurses go into those conditions with, there are certain things we can fix for them and make better for them, but the underlying condition is not fixable. I'm helping you manage it to improve your quality of life or to prevent this from becoming a bigger problem.
Right.
So this maintenance idea applies to nursing as well, but there was no culture shock. It was like kind of like, oh, I know I don't have to improve them. It's the need for skilled care. But for therapists who define themselves by improvement and improvement alone, maintenance is still a touchy subject.
Well, you even changed the word, Cindy, to make people
Yes,
more comfortable. You even
because
changed the
people
word.
well, they look like you swore in church.
Yeah.
When you say, let's talk about maintenance. No,
What? That's a
no,
word we were
I
told to
don't
never
do it.
use. We were
I
never to
don't do
use
it.
maintenance or endurance in our documentation.
Yes, so we've christened it stabilization of function, which is all it is.
Yep.
One path is I'm trying to improve it, and the other is I'm trying to stabilize it. And so the point of today is not to go into the nitty-gritty of what is maintenance and what you need to consider. We have resources for that. I see this as a call to action because this whole I don't do it or I kind of do it or I'm still thinking really needs to stop. It is part of the Medicare Part A home health benefit. The same rules that apply there are also applicable to Medicare Advantage, no matter what they try to pretend in some cases. They are accountable to the provision of maintenance therapy. But this idea that, well, I'm not sure, I'll tell you, well, two truths. One, your agency is providing maintenance right now, whether you know it or not.
100%.
They are, because there are patients where there has been a period of improvement and the therapist chooses to keep them a little bit longer after that, not because of convenience, not because of personal relationship, but because in their gut they know that what the patient has gained may not be stable. They may have a complication. I'm not really sure that where I got them is going to be a stable plateau. So I see them for a little bit longer. I've seen this many times in the documentation. But Sherry, they don't call that maintenance.
Mm-mm.
So they bill all of it as restorative. And the classic scenario is a partial therapy denial.
Mm-hmm.
They knock off those last couple weeks, arguing there was no more improvement. And we say, oh, but Jimmo. And it's like, but you weren't improving those last couple of weeks. You were doing maintenance. You achieved a plateau. You wanted to make sure it was stable. So the idea that you aren't providing it is, I'm fully prepared to say, not true.
Yeah.
Every agency is providing maintenance therapy. It does contribute to denials when not properly identified. Also, a little test to figure out how well your therapists understand it is to take a peek at some of those eval onlys. Because what I see in eval onlys way more often is somebody gave them an exercise program, made an equipment suggestion, did a home modification, let's move these few things over, then documents no rehab potential and does not go back. If there really was no rehab potential, if there was nothing to be gained from therapy, then what was with the exercise program, the piece of equipment, and the suggestions? Because if you felt the need to contribute something, you knew there was something you knew that could help. But you get stuck in but I don't think I can make this better, no rehab potential, so then I don't pick them up. So you gave out an exercise program. Let's just use that example. How do you know it works? How do you know it didn't potentially cause a problem? Unintended. Now maybe they have more pain or more stiffness, or they're not familiar with doing exercises, so they have naturally occurring delayed onset of muscle soreness. They think something's wrong. They don't do your program anymore.
Right.
So following up to ensure that what you've recommended is an integral part of maintenance therapy. But on a bigger scale, out of frustration, Sherry and I have talked to some of the folks at Palmetto and said, okay, this burns in my head. I just need to know if I'm on the right track. So if an agency chooses, let's take a nursing example, that they're not going to provide wound care. They don't want to. They don't have nurses with that expertise. They don't like the supply costs. Now, some listening to this, Sherry, you're probably going, what? You can't do that. Yes, you can. You absolutely can say, I know that wound care is a covered service. I am not in a position to provide it, so my agency is not going to provide it. You can do that. But there are responsibilities with that. My intake department needs to know that. Anybody giving me a referral needs to know that, because if this patient has a wound, we can't take them. And I need to know that if we get a referral and then we find a wound, not that that ever happened. You get especially a community referral, then you get out there and you go, oh, wow, nobody mentioned that thing. I can't just ignore it. I can't say, well, we don't do wounds here, so whatever that is on you, good luck with that. No, I would have to then try to find a alternate home health provider that does do the wound care.
Right.
We took that to Palmetto and said, is there any difference between that and when an agency says, well, I don't provide maintenance? And they said, no, it's the exact same thing. That if you don't provide maintenance, then that needs to be disclosed. That needs to be disclosed to referral sources, to intake. And you still have to be knowledgeable enough about that part of the benefit that if a patient qualifies for it and is in need of it, then you need to refer them to another agency that provides it. Now, don't give me, nobody around me provides it. That's not an excuse. We have to know this and disclose it. And this took on a whole new meaning, Sherry. You remember the conversation we had with Mary Carr from the Alliance about the new COP.
Right.
That went into place about, you have to let people know what you can provide, what you can't provide, if there's changes in that, all the logistics of, oh my gosh, we have to do this new COP. Yeah. If you don't do maintenance, you have to disclose you don't do maintenance.
Right. And let me be very clear. Palmetto that Cindy is referring to, some of y'all are on this call, possibly clinicians who don't know who Palmetto is. Palmetto is a fiscal intermediary in home health that takes the rules of CMS and pays the agencies, and they do the audits. They're responsible for the edits, the appeals, all of that. So Palmetto is one of those. There's several others in different regions of the country, but Palmetto is one that is who we had as an audience that day, and had the opportunity to ask that question. So just wanted to clarify that for
Right.
folks that didn't know.
So with that new COP, that upped the ante. That if you don't provide any part of the benefit, it has to be disclosed. Maricar confirmed that maintenance would absolutely fall in that category of disclosure. So what I don't understand, again, we're 15-ish years later from the Jimmo decision, and there's still this, well, I can decide. I'm not sure. I don't want to. I don't think it's a good idea. We don't have that luxury.
Nope, it's not
We,
a
we don't
choice.
have that power to say, this is something that is a covered service. I'm not going to do it, and I'm going to pretend it doesn't exist. Or my therapists don't understand it. Well, then they need to get themselves educated about this, because we've had folks that say, listen, I attended your education. I totally understand it. I don't want to do it. It's no different than wound care. Okay, therapist, you don't do it. You personally don't, but that doesn't change the benefit. So you now, from the education, understand what's involved in maintenance. If you have a therapist on the team who does this, then when you encounter someone who needs maintenance, they need to be transitioned to the other therapist. Your personal decision about not doing something doesn't mean you're able to cut it out of that beneficiary's benefits. And so, Sherry, I know I'm a little wound up. I can see my face is turning red. But I guess I'm just frustrated this many years later to still kind of encounter the I'll think about it. There's no timeline to think about it. You're
Right?
either doing
Agreed.
it or you're not doing it. And if you're not doing it, you got to disclose it. If you are doing it, you got to make sure you're doing it right. You got to make sure that the documentation, the orders, and no, I'll give you a quick tip. Just putting the word maintain as many times as humanly possible into the documentation will not save you. I had someone recently, Sherry, when I looked at some of the goals that they were writing for maintenance, and I asked about objective parts, the measurement part of a goal. I was told that tests and measures don't apply to maintenance patients. They're only to measure improvement. Okay, that's false as well. That's another truth moment today,
Yeah.
is that how do I know I've stabilized this patient's function if I don't quantify something?
Right.
So if the problem you're having, let's say with ambulation, is balance related, I don't think I can get it better, but I don't want it to get worse, then I have to have a way to objectively measure your balance, not fair minus. Objectively manage the balance and then provide your intervention, measure it again. Yeah, it came out nearly the same. That's called stabilization.
Right.
I know, and we put in that book, Sherry, as you well know, I believe therapists are addicted to improvement.
Yes.
They are just so focused. You even see it in our restorative documentation, sometimes to the negative, that the reliance on improvement almost gets to the, well, yeah, the patient walked further, bathed with less assistance, but you're not documenting what you did to make that happen. Almost like with improvement, as long as I keep showing improvements, then my service is considered medically necessary. No, because the daughter could have dragged him 10 more feet than yesterday. Why did it take you? What did you contribute that they now need less assistance to get their shirt on and off? Without your contribution, improvement for the sake of just existing doesn't say therapy is actually medically necessary. So, an interesting sidebar, Sherry, to me is when we've worked with agencies about maintenance therapy and what you have to think about for documentation when you've lost your improvement safety net. It also tends to improve overall documentation,
Yes.
because now you realize that the trajectory is for improvement, but the skill is not just in something being bigger or less. It's in what you had to do and could only do because of your particular training to actually make that occur. So there's a lot involved with it, but Sherry, again, I don't want people to say she just got all riled up to plug their own products. There just aren't that many products out there. They're not really owning this issue other than here's the regulation, read the regulation, you can do it. And agencies have tried that. And then they're like, but my therapist, they're being real difficult. Give them a little bit of grace. That big old, oops, it wasn't ever true that improvement was all you could do. Um, I've talked about, I think they go through almost the stages of grief.
Yes.
So we've seen therapists be angry that nobody told them about this before. We've seen therapists genuinely grieving that now they realize there are patients they could have kept. And in good faith, they thought they were following the rules and they discharged him. And they're realizing now, wait a minute, this is the patient I could have done more for. But after 15 years, the moment of grace needs to be moved to a moment of action. We can't just keep saying, I'll take it under advisement. I'll put it on my plan for next year. It's in the benefit today. And we have to make some decisions about what are we doing with it at the agency level. And if there's issues that need to be addressed, how do we plug into the right resources? Because what you don't want to do is read the reg. And now everybody's like, well, I keep my patients for months and months and months. Isn't this wonderful? They're on service so long. Not if you can't defend that that care is in fact meeting qualifying criteria and that it is in fact skilled, reasonable, and necessary.
And in the description of this, again, I'm going to leave the link for the book, but I'm also going to leave the link for the $7 product that introduces you to maintenance, and it gives you an idea of what our maintenance training that is already in the can do for your agency. But we also provide custom education. But I just want to leave everyone with this thought: maintenance is not a choice. Period. It's not a choice. Maintenance care is not a choice in home health. It's also not a choice in all the other post-acute settings, but we focus mostly on home health. And so we want home health agencies to understand that. Cindy, do you have any closing thoughts?
Well, I think in our interactions with agencies, when we help them understand maintenance, there tends to also be a light bulb moment. There are similarities between this and observation and assessment and management and evaluation for nursing. Even saying those, I'm sure there's at least one listener who went, "Oh, oh
A little
no,
twitch. Yeah.
no, no, we do not do M&E." You, you don't get the option,
Yes.
okay? Management and evaluation, observation and assessment. We know how we got here, which was there was a period of time everybody went crazy and used a whole bunch of it, and then audits happened, and they, to a certain extent, justifiably said, "Wait, no, you're not. This is not how this works." And so we rebounded and went, "We don't do that anymore." Shh, don't tell them it's a thing. We never, ever, ever do that anymore. Again, I would argue nursing is doing things that are management and evaluation. They
Right.
are doing things that are observation and assessment. And we see denials because you didn't call it what it was. So we often see by extension that the let's look at maintenance comes along with those other two to say, how do we apply this correctly so the beneficiary receives what they deserve and they're entitled to without going too crazy and over providing when we shouldn't, but also not so afraid we refuse to.
Mhm. It starts with education. It starts with
Mhm.
education and training, and going from there and making the right decisions for your patients. Like you said, if you don't provide this care, you need to find an agency that does. And your because your burden of your responsibility is towards that beneficiary and making
Yes.
sure they get what they need. So there's no more discussion. Maintenance is not a choice. Look for the links in the description of this podcast. And again, Cindy, you usually say the end of about people sending us ideas. So you go ahead with that, and then we'll.
Yeah, if you want to share your thoughts about today's topic or you have some other ideas for future podcasts, please just let us know. We want this to be useful to the industry, as well as cathartic for us.
Exactly. Thank you so much for listening, and be safe out there.